Welcome to the lecture for Chapter 6, Communication Assessment and Intervention, Evidence-Based Practices. Our focus questions for this chapter will include looking deeper at what is evidence-based practice, or EBP, what is assessment, what is intervention, and what are some common approaches to intervention for communication disorders. First, we'll talk about the roles of SLPs and audiologists. There are numerous roles and responsibilities. Speech-language pathologists and audiologists will serve as part of a team, whether you're in a hospital or a school setting, a private clinic. You will be part of a team that will be made up of people from different disciplines, occupational therapists, physical therapists, some nurses, maybe doctors, psychologists. You will be, as part of that team, you'll be looking at how to assess the clients that you are seeing and diagnosing what some of the problems are that they're having. And then as follow-up to that, you'll be planning intervention and treatment. Let's take a closer look at evidence-based practice. It is the integration of current scientific evidence, clinical expertise, and client perspective in order to provide the best possible outcome for the client. You'll hear in the clinic at ASU a lot of the clinical educators talking about evidence-based practice or what is best practice. And if they say what is best practice, they're referring to what does the research show as being the most effective type of treatment for a specific disorder in a specific client. So in evidence-based practice, you'll see that in the middle of the diagram. And it's going to be a compilation of the best research evidence, clinical expertise, and the patient's values, kind of all intertwined to come up with what evidence-based practice method that you'll be using for a specific client. You're not just going to look at the best research evidence and say, this is what we're doing because it's the best thing that the research says. Because you're going to want to use some of your clinical expertise to enter into your decision-making process also. You're also going to consider the patient values. If the patient doesn't believe in the type of therapy or the strategies that they're using, the chances of them actually practicing these strategies at home are slim to none. And they're probably going to give up on therapy pretty quickly if they don't feel that their values are being considered in as part of evidence-based practice, the plan for the evidence-based practice. As far as assessment goes, assessment being the systematic process of gathering information about an individual's background, history, skills, knowledge, perceptions, and feelings. The assessment process can involve many people and disciplines with diverse knowledge, skills, and experiences. Test can be one part of a complete assessment. And I think that that's an important thing to note, that a test is just one part of a complete assessment. You might think that a test, you give somebody one test and you can make a diagnosis. Oftentimes that's not the case. Obviously, as you become a more experienced clinician, you're going to be able to walk into a situation and say, oh, I think that the problem is X, or I think the problem is Y. maybe even before even doing an assessment or a single test. But really, what's best for the client would be involving observations and tests and case histories, and involving people from other disciplines and their experience to come up with to use all of that as part of the assessment. Purposes of an assessment are to identify skills that a person has and those the person does not have in a particular area of communication. I think it's important here to note that it's just as important to identify the skills that a person does have or does exhibit, just as important as trying to figure out the skills that a person does not have. That's an important thing because you are going to take what the person can do or is able to do, and you're going to use that as a building block to help them you're going to use their strengths to help them to overcome some of their weaknesses. Another purpose is to guide the design of intervention for enhancing a person's skill in a particular area of communication, and to monitor a person's communicative growth and performance over time. So the assessment would serve as a sort of baseline for what a particular client is able to do at a certain period of time, probably at the beginning prior to treatment sessions. And an assessment also can be used to qualify a person for special services, especially in the school system. They have guidelines that they use to qualify students for services, and the students will need to have certain scores to be able to qualify for those services. Let's talk a little bit about the assessment process. First, you would start with a screening and a referral. The client would need to be referred depending on what type of facility that this would be, where the referral would be coming from. If you're in the school, you might hear of people referring to it as a DEC 1 or a DEC 1. And what that is a referral. Typically, the teacher is involved in that, enlisting a student's strengths and weaknesses. And it usually takes place prior to a screening in the school system. A referral could also obviously come from a doctor, maybe a pediatrician who would refer a client to a speech language pathologist or an audiologist. A referral can accompany a screening. And just really is kind of the formal way that a screening is requested, would be by a referral. Screening is the use of a test or task to conduct a quick check of an individual's performance in a particular area. You all probably have had a hearing screening at some point. This provides a quick screening of your hearing, or a probe into your hearing to see whether you can hear at functional levels or not. It also could serve as a precursor to the possibility of needing further assessment. Obviously, if you pass a hearing screening in both ears, there would be no need for you to have further evaluation or further assessment. In reference to speech and language, you might give someone a speech and language screening, which is a quick version of the actual evaluation to see if further evaluation is necessary. Okay, designing and administering the assessment protocol. So you've been through the screening and you've been through a referral. And the professionals will use their clinical skills and knowledge of current research to design an assessment for each client that they see. And the professional would use many different techniques to obtain information about areas of concern. Some of the common techniques for administering an assessment protocol might be chart reviews or interviews, observations, questionnaires and surveys, formal tests. Okay, then jumping to interpreting of assessment findings. When interpreting assessment findings, it's important to not skew those assessment findings. Clients usually are waiting with bated breath to find out the results of an assessment. And so when you interpret them, you need to make sure that you have read through the clinical manual and understand how to interpret the assessments that you're giving. After interpretation of assessment findings takes place, the next step would be to develop an actual intervention plan. And in doing this, a clinician would use the assessment process to develop an intervention plan based on the strengths and needs of the individual. And in doing this, you'd be identifying treatment goals, describing the possible length and frequency of treatment, and describing treatment contexts and activities. The goals that are identified are going to vary with different types of communicative disorders. For instance, a person with a swallowing disorder, the goals are likely to focus first on ensuring safety while swallowing, and second on improving quality of life. Looking at a child with a disorder of speech production, goals might focus first on developing other means of communication so that the child can make his or her needs known, and then focusing secondly on improving speech intelligibility. The next step in the assessment process is monitoring progress and outcomes. So assessment would not be just a one-time activity that stops once you make a diagnosis. Assessment is an ongoing process that's going to monitor process and outcomes for the client. It's used to monitor a client's progress during treatment, to modify the treatment plan as progress is made, and determine when a client should be discharged from treatment. So when you are monitoring progress, you might want to, if the child, or if it's a child, an older child or an adult, you might want to involve them in the monitoring progress and have them do some self-monitoring before discharge occurs. Okay, we talked a little bit before about the screening and the referral. This goes a little bit more in depth. So screening is the delivery of a test or task that provides a quick check. And there are two types of screenings that can be done with young children. A developmental screening and an injury-related screening. Okay, we talked before about a referral often accompanying screenings and describing the process by which the involvement of speech, language, and hearing professional is formally requested. Talked about a doctor and a nurse sometimes making those referrals. And then the speech language pathologist or audiologist will determine whether a more comprehensive assessment is warranted. We've already talked about designing and administering the assessment protocol. Here it's kind of spelled out for you. Looking a little bit deeper into interpretation of assessment findings. The steps to interpret these assessment findings include diagnosis, a differential diagnosis, meaning a little bit more specific of a diagnosis. For example, if it's a articulation disorder, that might be the diagnosis, and a differential diagnosis, you might look a little bit closer into that and find that a child has a certain speech disorder that might be a little bit more involved, such as apraxia of speech. And you can determine the severe, very mild, mild, moderate, severe, and very severe. These severity levels are important when, especially when Medicaid is involved, because Medicaid billing will require you to specify the level of severity. They base the number of visits that they will approve on the level of severity that a client is exhibiting at a certain time. And then characterizing the patient's prognosis, which is just as it says, trying to figure out if the client has a good support system in place, which would be helpful in having a good prognosis for therapy. So when you're developing an intervention plan, you are going to talk about we'll talk about components of the intervention plan. You're going to want to identify treatment goals, the length and frequency of treatment, and describing treatment context and activities. Characteristics of goals. Goals need to be functional goals. And we talked a little bit before when we were talking about evidence-based practice, that if a goal is not functional and something that the patient or the client thinks is important to them, then chances are they're not going to want to work on that goal, and it's not going to be effective in treatment. The goals need to be measurable with a level of, or a percentage of accuracy, and the goals need to be attainable. You want to make sure that the goal is something that your client is going to be able to reach and make progress on. You don't want to be working on the same goal for a year. Obviously, that's going to be disheartening to the client, and probably also to you as the professional, that little or no progress is being made. So in monitoring progress, we've talked a little bit about that, touched on it a little bit more in depth. Assessment, monitoring progress is ongoing and monitors progress and outcomes for the client. And it's used to measure their progress during treatment, and to modify the treatment plan, and to determine when a client should be discharged. How are assessment instruments categorized? Professionals use a variety of instruments to identify an individual's strengths and needs in communication, and to develop an assessment protocol that is sensitive, comprehensive, and non-biased. A variety of instruments are necessary to accomplish this. You can use norm-referenced instruments. These would be your standardized tests. Formal, or referred to as formal testing. So in norm-referenced instruments, you're going to be using that to compare an individual's performance in a particular area with that of his or her same-age peers. And criterion reference tests, which is also considered formal testing. They're used to determine an individual's level of achievement or skill in a particular area. Criterion is used to indicate that the individual's performance is judged against a particular standard or criterion. Performance-based assessment can also be used. You're going to be looking at how that client performs on particular tasks. Dynamic assessment is used to analyze how much and what types of support or assistance are needed to bring an individual's communication or performance to a higher level. We touched on dynamic assessment in one of the previous chapters. Dynamic assessment is looking at what a person can do dependently by looking at their learning potential. With a standardized test, the test must be given in a uniform and scripted manner so that it is given in exactly the same way to everyone who takes it. A normative sample is a group of individuals who were given the test to identify standards of performance at specific age levels. And standard scores are used with norm referenced instruments. They are the index that identifies how a person's test performance compares to that of their normative peers. And these are all part of the formal testing. Standard normal distribution derived from mathematical models of probability regarding how scores will range from a skill or aptitude that is assumed to be normally distributed within the population. Terminology used with this type of distribution: raw score, normal curve, mean, standard deviation, and percentile rank. The good news about all of these terms is that you will typically find in an examiner's manual for a norm reference test that there are tables that refer to each of these terms that will help you out in chart form, and you can look up a raw score to figure out the standard score, percentile rank. So you don't have to be a statistics guru necessarily to be able to score a test, which is good news to me because I'm definitely not a statistics guru. Looking at this curve, you can see where a client may be different above or below the mean for the data. In a criterion referenced assessment, again, it determines an individual's level of achievement or skill in a particular area of communication. Instruments require establishment of a clear standard of performance. They require design of specific tasks and must provide clear guidelines for interpretation. A performance-based assessment describes an individual's skills or behaviors within authentic contexts of use, such as home, in the workplace, in the classroom, or in the community. It's going to look at how they perform. Communicative skills are highly influenced by context, is one of the rationales for looking at this type of assessment, and traditional models of assessment are of limited use in planning treatments. Techniques used artifact analysis and portfolio analysis. Okay, looking at dynamic assessment, analyzes how much and what types of support or assistance are needed to bring an individual's communicative performance to a higher level. I touched on this a few minutes ago. This is just looking at it more in depth. And Leo Vygotsky was a big influence in MEC assessment. He's a name associated with that. Progress monitoring assessment is analyzing an individual's progress during a course of intervention and is used to compare actual rates of growth to expected rates of growth and adjust intervention techniques accordingly. Individual growth and development are indicators for this type of assessment. RTI, or response to intervention, is weekly or biweekly assessments used to assess progress. You will hear the term RTI used in the public school system. The response to intervention is currently used as a precursor to referring a child to special education services. What is intervention? Intervention refers to the implementation of a plan of action to improve one or more aspects of an individual's communicative abilities. Qualities are effectiveness, efficiency, and it's feasible. Intervention purposes include prevention, remediation, and compensatory. The goal for intervention planning is targeted communication achievement of an individual. The procedure is the clinician's plan of action, and the goal characteristics are functional and meaningful, measurable, and attainable. And we touched on that before. Intervention planning has different phases. In phase 1, the professional sets long-term goals for a client, the anticipated outcomes of therapy. In phase 2, the professional sets the short-term goals that will lead to the desired long-term goals. In phase 3, the professional sets session-level goals for a client that are written in measurable and observable terms. There are different intervention models that are used. There's pull-out or co-teaching or parallel instruction, and intervention consultation. Let me go back to that a minute. In pull-out directed service, a therapist or an educator provides an intervention to an individual or a small group. This type of service is pretty common in all clinical settings, schools, clinics, hospitals, nursing homes. Then sometimes co-teaching or parallel instruction model will be used, where 2 or more therapists or educators work together to provide intervention to an individual or group. It's a collaborative model, and it's definitely becoming increasingly common with early intervention in school-based programs. I work in private practice and often intertwine with other early intervention specialists, occupational therapists and physical therapists, sometimes psychologists, sometimes behavioral specialists, and parents of 2- and 3-year-olds typically don't want or need for their situation, especially if treatment is occurring in the home, for their front door or their home to be a revolving door. So sometimes co-teaching and parallel instruction will be used where 2 different disciplines will be working together, occupational therapy and speech therapy, for instance. And then another model is intervention consultation, where the therapist or educator provides guidance to other professionals or to family members concerning assessment data and intervention approaches, but does not work directly with that individual. This is mostly used in clinical settings. Other approaches are a behavioralist approach, linguistic cognitive approach, social interactionist approach, family-centered interventions. And a little bit more in depth, a behaviorist approach is based on classic learning theory, which emphasizes the importance of the environment for shaping behavior, in particular, the influence of consequences on behavioral change. Clinicians are responsible for identifying observable and measurable goals. You'll hear that over and over about observable and measurable. That's just the gold standard of how goals are developed, being observable and measurable. Clinicians are also responsible for specifying the level of mastery at each goal, mastery level, 80% or 3 out of 4 times, which would be the equivalent of 75%. However you write those up just kind of depends on what population you're working with, what type of facility you're working in. Clinicians are also responsible for controlling each intervention session, collecting data in each session. In a linguistic cognitive approach, it's based on theories of developmental psychology and cognitive science, which emphasize developmental sequences and underlying rule-governed organization of communicative behavior. Wow, that sounds really authoritative, doesn't it? The parameters of this type of approach are that goals of communication acquisition, the when and the how and the why of communication acquisition, helping the individual learn, that's supposed to say learn, the rules that underlie successful communication. And the learner is engaged fully in the intervention process. Children learning the underlying rule for how to make requests by combining the verb want with any number of actions or objects like want go, want car, want, suggests that children do not need to be taught every possible way to produce a request. Rather, they need only learn the general underlying rule governing this communicative category. That sort of sums up in an example the linguistic cognitive approach. The social interactionist approach is based on theories of developmental psychology that emphasize the importance of social interactions among individuals as a critical means for development and learning. Again, the name Vygotsky is tied to this type of approach. And terms that you'll hear used with this are social plane, psychological plane. Let's back up. A social plane is the knowledge contained within the interaction between two individuals. A psychological plane is the knowledge that one possesses internally and independently. A zone of proximal development refers to the range between an individual's independent performance of a particular skill or behavior, in other words, what he or she can do by himself or herself, and the person's level of performance when helped by another person. And that is what he or she can do with assistance. And then the last part of that is scaffolding. And it's the assistance provided by another person to raise an individual's level of performance. Scaffolding provided within an individual's zone of development is a primary vehicle of learning and is viewed as the essential mechanism for social interactionist interventions. Family-centered intervention. A family systems theory is the family as a whole is greater than the sum of its parts. So the treatment goals for this intervention emphasize an individual's participation within and access to family activities and contexts. And it incorporates family members' perspectives regarding viable treatment approaches. An example of this that we use in our clinic here at ASU is a parent program, and it's called It Takes Two to Talk. And we refer to it as Hannon. We have parents that come in once a week, and learn strategies to implement with their child during the week. They actually have homework. They go home and do the homework with their child and report back the next week about what worked, what didn't work, how do we need to change things, how do we need to tweak things with their specific child. And that is the end of Chapter 6. And thanks for listening. The discussion questions will be posted.